For that talk, I was really focused on treatment for relapsed and refractory CLL. And that's really the area where the marked evolution of CLL treatments has occurred first. I've been in practice now for about a decade, and if I were to think back to how we were treating CLL 10 years ago when it had relapsed after prior therapy, we were still very much wedded to chemotherapy, mostly drugs that were given intravenously, sometimes in combinations with immunotherapy drugs like monoclonal antibodies. But the idea of more specifically targeting the abnormal biology of CLL was something that was just beginning to emerge. In many of the trials in which my institution participated or which I participated in as an investigator, were focused on trying to maximize the benefit of chemotherapy. And that really probably reached its peak in the early to mid 2000s. And at about that point, some fundamental understandings about the biology of CLL came to be exploited clinically. And the one that's most pertinent to what we presented at the symposium is understanding a little bit more about what drives CLL growth and CLL survival. CLL growth is in large part driven by signaling through the B cell receptor. That's the business end of any B cell, but in CLL cells, it's kind of stuck in the on position. So specific drugs that are designed to inhibit downstream signaling kinases from the B cell receptor have entered into the clinic over the last 5 years and are transforming the way we think about CLL. But we've also begun to target the pro-survival pathway that's best expressed as expression or overexpression of BCL2, which is common to a lot of low-grade lymphoid malignancies. And the specific drug there is a drug called venetoclax. It's the only one yet available in its class, and the investigation with that drug is ongoing.